Good evening. How are you, sir?
Fine also.
You're, is that right?
Yeah, we are all right.
Yeah. It's raining there, one. Okay.
But not too hard.
Is this the rainy season?
Maybe end of April it will be stopped.
Okay. Yes.
What we sky and very blue sky right now.
Okay.
Because
I
frequently even just not so hard rainy, it's good.
I would like very much to be with you, Professor Maliawan. It's about 25 degrees Fahrenheit in Chicago, and we've had snow. So it's greatly different from where you are, and I'd rather be with you. Okay.
I imagine that if there's any snow here, maybe I will enjoy it. But not
Okay. As long as you don't have too much. Okay.
Good evening.
Good evening. I'm trying to fix it now, so it's a little bit late. Yes, Dr. Peter, I'm joining the meeting.
Yep.
Just a moment, trying to fix my internet. Good evening, Max.
Good morning or good evening to you.
Yeah. Good morning to you.
Good evening to you. Yeah.
Yeah.
How are you?
Fine, Max. Thank you
Good
very
to hear
much.
your
And how are
voice.
you?
I'm fine, thank
Okay.
you. I'm very well, thank you.
So there is no mask mandate anymore in the States,
I
right?
think that's correct. It's a varied situation in Chicago, and Illinois. The mask mandates have been dropped. I think even in California, and I think generally in New York, around all of the states. Interestingly enough, there are a few legal challenges to the dropping of the mask, to the elimination of the mask mandates. And I suppose there are some folks, respectfully spoken, who still that the mask service. But as far as the governmental mandates are concerned, both state, city, U.S., it's been dropped.
So it means that some of the people does not agree with the government to drop the mask. Some are protesting.
I think a few people. It's exactly correct,
Okay.
and it's not everybody has a right to agree or disagree, and so it's
Yeah.
but no effect to anyone, of course. But it's for the most part, I think people are happy
Okay.
that the mask mandates.
Yes, it's true. We have used the mask for too long, I think.
Yes.
But even if the people are choosing still the mask, it's okay. I think
Yes, it
there
is.
no
Absolutely correct. I agree. And how Indonesia have the governmental mandates been dropped? Or?
No, for the mask, using the mask, the mandate is still there.
Okay.
So all of the prevention measures is still there, but now the traveling requirements are relaxed. So before we have a negative PCR test before we travel one place to another. Now not so. So if you already vaccinated twice, you do not need to know that you have a negative PCR or antigen test for traveling.
We will get started.
Okay.
We will get started very soon.
Yes. Sorry.
I'm sorry that I could not show my video. I'm trying to figure out and fix the problem, but so far it doesn't work. Very sorry. Maybe I cannot expose, but I'm still trying. Good morning, good afternoon, and of surgery section to open the venue, and I would like to welcome all of you, dear all participants from Indonesia and worldwide, particularly to our speakers. First, to our guest speakers, Professor Nicolaas C. Budhiparama, MD, PhD, and then Dr. Sjahjenny Mustokoweni, MD, Pathologist, and also to Dr. Herdiani, Sulistyo Putri, Anesthesiologist, and all the office bearer from the International College of Surgeons, Professor Lie-Kwan, the World President of the International College of Surgeons from Taiwan, and the World's Executive Officer, Mr. Max Downham from Chicago, USA, as the World Executive Officer, and also from the national or from the section office bearers. First, Professor Dr. Sri Maliawan, the President-elect of ICS Indonesia, Professor Hendy Hendarto, the Vice President of the Indonesia section, Dr. Franciscus Arifin, the section secretary, and Professor Andi Asadul Islam, the Vice President of the Indonesian section. Also, all dear participants, my name is Dr. Peter G. Manopo. I'm the coordinator of this surgical forum, and I will be your moderator of this session. So today, in the 25th chapter of the surgical forum, with the theme, the surgical team, we will have all the speakers and that the discussion afterwards. Now we come to the opening session. And for the first opportunity, I would like to invite Professor Sri Maliawan as the President-elect of the Indonesian section to address the opening speech. Professor Sri Maliawan, the floor is yours.
Thank you, Dr. Peter Manopo. First of all, good evening, good morning, good afternoon, and good evening. Welcome to all of the participants of this webinar. On behalf of FICS Indonesian section, I would like to welcome you all to this 25th surgical forum that of ICS Indonesian section. The title was the surgical team. Especially welcome to our three distinguished speakers. Let's enjoy the webinar that were organized by Indonesian section. To moderator, thank you. Thank you.
Thank you, Professor Sri Maliawan. For the next opportunity, I would like to invite the President of the International College of Surgeons, Professor Lie-Kwan from Taiwan. Professor Kwan, the floor is yours. Professor Kwan, are you on the line? Okay, I will skip. So I would like to invite Professor Hendy Hendarto, the Vice President of the ICS Indonesia section, to address the scientific notes. Professor Hendy Hendarto, the floor is yours.
Thank you, Dr. Peter. Good evening, everybody. Good morning, Max. Good afternoon, friend. Welcome and thank you for joining the International Pathological Forum, Chapter 25, the International College of Surgeons Indonesian section. From the scientific note, I would like to inform you the most popular article in the Annals of Surgery journal that published on February 2022. The title of the article is "The Risk of Post-Operative Complication After Major Elective Surgery in Active and Resolved COVID-19 in United States." The objective is to assess the correct association between the timing of surgery relative to the development of COVID-19 and the risk of post-operative complication. The conclusion of the article, the major elective surgery 0 to 4 weeks after SARS-CoV-2 infection is associated with the increased risk of post-operative complication. And the surgery performed 4 to 8 weeks after SARS-CoV-2 infection is still associated with the increased risk of post-operative pneumonia, whereas surgery 8 weeks after COVID-19 diagnosis is not associated with increased complication. It means that surgery 8 weeks after COVID-19 diagnosis is safer surgery. That's all I think about the scientific note. I hope we'll stay healthy and stay safe. And finally, thank you for all speakers for sharing your experience. Thank you very much for your attention. Thank you.
Thank you, Professor Hendy Hendarto, for addressing the scientific notes. For the next, I would like to invite Mr. Max Downham, the ICS Executive World Officer, to address the ICS updates. Mr. Max Downham, the floor is yours.
Thank you very much, Dr. Manopo. Professor Mustokoweni, Professor Sulistyo, and Professor Budhiparama, as well as Dr. Maliawan, Arifin, Hendarto, Asadul Islam, and of course you, Dr. Manopo. Good morning, good afternoon to, I think, Dr. Budhiparama. I'm not sure where he is, but at any rate, I'm assuming in Europe. Thank you. I'm happy to be a part of this, and I'm very honored to be invited by the Indonesian section to speak a few words. On behalf of Professor Lie-Kwan, our world president, of whom we're very proud. As I've said earlier, she was born in Indonesia, and so she has a very close relationship to all of you in Indonesia. And on her behalf, I give these remarks. The International College of Surgeons, I've participated in just about all of these chapters. Dr. Manopo, as you know, missing one or two, but I thought I would talk about the organization just a little bit for a couple of minutes. One is that the International College of Surgeons is organized in terms of 6 federations. And the Pacific Federation is represents the Indonesian section, and the Pacific Federation Secretary, there's a secretary for each of the 6 in our governance, is located in Sydney, Australia. At this moment, on behalf of World Corporate Secretary, Dr. Clement Chan, we're soliciting interest for positions in the Pacific Federation, as well as the other 5 federations, those positions being Associate Federation Secretary and Assistant Federation Secretary. So if any of the leadership in the section or other members have an interest, please let me know or advise Dr. Manopo, and he can relay it to me. I think the Indonesian section, I know the Indonesian section has been and continues to be very, very active, and we are so proud of the Indonesian section and all that you do. You're very active, and so for those of you that don't know, the world body of the International College of Surgeons has great admiration and respect for the Indonesian section. The other thing is that this time of year, we're focusing on membership. If any of you in Indonesia have ideas on how to increase membership, and make it more active. We would love to have those ideas. The old saying is that the world is short on ideas, new ideas, good ideas. So that's a comment that I make. So I thank you very, very much, Dr. Manopo, Sir Maliawan, Dr. Arifin, Professor Indarto, and Professor Asado Islam for the invitation to be part of this webinar. I'm very honored, and thank you, Nopo. I'll give it back to you.
Thank you very much, Mr. Max Downham, for the updates of ICS. And for the next, I would like to invite Dr. Franciscus Arifin, the section secretary, to address the section notes. Dr. Franciscus Arifin, the floor is yours.
Thank you very much, Dr. Manopo. I think for tonight, there is no update for the national section. I'm just highlighting what Max has already there is we have reorganized the international ICS persons, so there will be some opening for the positions in the federations, and so we are in the Pacific federations, Indonesia. So any members, and we can, if there is any members that would like to apply for this position, there will be further announcement. Thank you very much, Dr. Peter. That's all.
Thank you very much, Dr. Francisco Arifin, for your section notes. And now we come to the scientific session. For the first speaker in this session will be Dr. Sjahjenny Mustokoweni. She is a pathologist, and she will talk on accuracy in frozen section examination. Dr. Sjahjenny Mustokoweni, the floor is yours.
Thank you, Dr. Peter. Good morning, good afternoon, and good evening, especially to Max Downham, Mr. Downham, far away from Chicago, and to Prof. Nico, Prof. Lie-Kwan, Prof. Herdi, Prof. Maliawan, Dr. Frans, and my colleagues, Dr. Herdiani, and all colleagues of this forum. Thank God that all of us are fine and healthy. And thank you for the ICS Indonesian section for the opportunity for me to share our daily practice about the frozen section. First, I want to tell about the role of anatomical pathology in diagnosis of the disease. First is to determine an accurate diagnosis. Slide, please. To determine an accurate diagnosis, then to provide the pathological staging, clinical staging, and the prognosis. And also we suggest an advanced examination, then follow up the patient. And we have to remember that the pathological result has a legal aspect. All of the insurance need the examination and the result from the pathology. Next, the method in anatomical pathology examination consists of preoperative, during the operation or intraoperative consultation, and postoperative. Postoperative is our routine service. Preoperative, we have the FNA, fine needle aspiration biopsy. It is the goal is to screen the patients in oncologic centers in order to shorten the waiting time for surgery, and we have to use the triple assessment approach. The triple assessment consists of clinical findings, radiological, and pathological findings through FNA. If the three aspects are met, so the patient goes for the definitive treatment. whether they have a radical operation or in benignity, also it's only simple surgery. But if not met, IOC should be performed, and mostly is by frozen section. And frozen section usually during operation, during the operasi, and after that we examine with the histopathological routine. And if the histopathology we cannot solve the problem, then we go to the molecular pathology. Slide. Now, how to assess the specimen? This is the algorithm. In IOC or frozen section, there is two types of the disease. Perhaps it is a non-neoplasm or neoplasm. For non-neoplasm, it is okay. Perhaps it is just inflammation or infection specific, non-specific, or sometimes it's only just look like a lesion. But what about the neoplasm? There are three. Benign is easy to solve the problem, and the malignant, we can look whether it is a primary lesion or metastatic. But what happened with the pre-malignant? It is very difficult for us. This part usually makes us go to in a doubtful situation. Yeah, so that's why we need a discussion first, and many information pathology need. So triple assessment is really the key for the success of pathology result. And sometimes we have to wait for the paraffin section. So because frozen section cannot say anything. Next. The IOC consultation, the intraoperative consultation, there are three types. Frozen section is the most, and then FNA, and the third is a touch imprint cytology. And the sample can be obtained from biopsy, perhaps from the tumor tissue or at the surgical margin. Well, the type of biopsy could be corneal biopsy or incisional biopsy. Slide. Next. Yeah. You know that it is a difficult procedure, and we pathologists, we have to arrive at the correct decision within short time and under pressure situation based on our experience, our judgment, and the knowledge of the specialty and clinical medicine. Slide. This rapid frozen section means an intraoperative pathological diagnosis. Actually, it was 130 years ago, developed by Wells. Yeah? And then we have the microscopic examination, means it is a morphology. We need the fresh unfixed tissue, and the quantity of tissue will vary depending on the indication, the amount, and also the appearance of the tissue obtained. Slide. Frozen section is recommended for several situations, like to establish the nature of the lesion, the presence of lesion, the presence of benign lesion, and confirm the sufficient tissue is present for diagnosis, and establish the grade of the lesion, determine the organ of origin, and determine the adequacy of the margins. Slide. You know, this is one example of the quality of a specimen from frozen section. I will be headache, stressful, and also a little bit depressed when I got such specimen. Yeah. So what I'm going to say, it is an example of one of the technical problem we face during a frozen section. Slide. Next. See. Compare with this part. So quickly I can say that this specimen is from the lymph node. So this is one problem that usually makes not all pathologists want to go to do the frozen section. Slide. What about the thoughts in print cytology? Actually, it is a rapid assessment from that can distinguish between benign and malignant lesion. It is also required fresh tissue, and we used in conjunction with frozen section evaluation. And it can be helpful in diagnosing also hematolymphoid tissue. Sometimes we need this method because from the tissue we cannot decide what kind of tissue, except from the explanation from the clinical. Yeah, if we found the round cell or spindle type cell, it is a very very horrible, yeah, because the morphology is similar. Slide. So this is a technique with a slice that placed directly onto the fresh tissue, yeah, and we can stain as a Romanowski like in FNAC, and the result or the specimen appearance are similar with those seen in cytologically. So we decide from the cytomorphology. Slide. Modern technique of frozen section developed start of the cryostat in 1959. Yeah, it is a refrigerated box with the temperature -20 to -13, and the attending technologists will then process the tissue section by freezing with frozen aerosol spray and put onto the cryostat for sectioning. Yeah. So intra and intercellular water is frozen to produce a hard matrix to enable slicing on the tissue. So it is a different. In the routine, we use the paraffin, so we can cut the tissue easily. So the tissue section are cut and picked up on the glass slide, ready for staining, and then the interpretation to get the diagnosis. Slide. What about the frozen section compared with the formalin fixed paraffin embedded as our routine work? Yeah. Correlating the intraoperative frozen section. Frozen section provides rapid diagnosis, yes, but it should not be used to replace the FFPE tissue, because the FFPE tissue is the gold standard. Yeah. You know that frozen section is still inferior. What happened if we found the specimen like I showed you before? So it is still inferior comparing with FFPE. And the sampling of specimen is limited, and there are technical difficulties of getting good quality section and staining, such as if we got a fat or mucinous or non-metastatic lymph node, etc. And we have to remember that it's influenced the interpretation of the section by the pathologist. Slide. The advantage of frozen section, if all goes well, it just takes about 5 to 10 minutes to prepare the slides. And the time the pathologist takes to study it under a microscope and arrive at the diagnosis is in addition to this. So in one study that they found from 700 labs worldwide, found that 90% the TAT turnaround times were within 20 minutes, measured from the time the pathologist received the frozen section specimen to time that pathologist returned frozen section diagnosis to the surgeons. Slide. What about the limitation of the IOC? Some controversies of IOC usually due to difficulties for soft tissue. It is overlapping many types of soft tissue type and various biologic behavior, such as if we found the round cell tumor or spindle cell tumor. The second is impossible for bony lesion. We cannot do IOC for bony because we have to do the decalcification first for the bone specimen. For lymphoid pathology, like I told you before, except in the metastatic, because in metastatic specimen we can find some picture around the lymphoid cells. And even from routine lab tissue processing, it is causes the IOC becomes inappropriate with pitfalls, and the most of which is the danger of incorrect diagnosis. Slide. Limitation of frozen section. The first is from sampling errors, to include from poor sampling or limitation of the surgeons. Then the second is poor selection of appropriate tissue after crossing. Then extensive tumor degeneration or necrosis, poor assessment of capsular or vascular invasion, and searching sometimes for immature component in an ovarium teratome is rather time consuming and subjected to sampling error. Slide. The second is technical problem, include the freezing artifacts, poor quality section, bloated cell morphology, and poorly stained section. And the third is interpretative errors, include tumor that mimic the normal tissue, like signaturing cells in diffuse gastric carcinoma, chronic pancreatitis versus pancreatic carcinoma, and difficulty in assessing ganglion cells and hypertrophic nerve bundles in Hirschsprung's disease. Slide. What about the preparation of frozen section? Frozen section should not be treated as an emergency procedure due to the difficulty of the procedure and the availability of the technician. And then the close cooperation between the surgeon and pathologist is required if a meaningful frozen report is to be achieved. And the third, preferably, the case should be discussed beforehand between the surgeon and the pathologist. Next, and what we need to know, sure, the close cooperation and case should be discussed, and pathologist should not be treated as a mere technician, and the relevant information should be conveyed and must be supplied verbally when making an appointment. And the request form must be adequate and relevantly filled, including the patient's particulars, relevant clinical history, previous tissue biopsy or FNA findings, purpose of the consultation, type of tissue or location of biopsy, and the radiological findings of the case, especially for musculoskeletal or bone and soft tissue tumors. Slide. This is one about the accuracy of the frozen section. It is from India. They do the research about the organ-wise accuracy of frozen section. The most cases is breast with accuracy 92%, 100 to thyroid, to ovary, to testes, but we know that the number of cases is very small. Yeah. Next, from Brasilia, they have more patients, more than 1,000 patients, and the concordant or the accurate frozen section results, 100% is to uterus, and then to sentinel lymph node, breast, and ovary, and the for central nervous system, they also got the 100%, lung, skin, and omentum. Omentum usually for the metastasis cases. Yes, this is showing that accuracy of frozen section is high enough. Slide. This is the activities of pathologists and technicians around the operating room. Yeah. For the frozen section, we got the specimen and fill the form, and then in PET lab, we have to measure everything about the gross. We have to make a description and then choose the part of the specimen, which one that we will be processed for frozen section. And we have the cryostat machine, and then the pathologist will examine. Then at last we can have such beautiful slide. Yeah, it is with the adenocarcinoma slide. And for the conclusion, the IOC using frozen section is very useful, but needs to be aware of its indication and limitation, legal aspect as consideration, and keep the triple assessment and limitation of frozen section, including sampling error, technical problems, and interpretative error. Frozen section is an elective procedure that needs close cooperation between surgeons and pathologists, while the case should be discussed beforehand. Slide. Next. The results suggest that correlation of frozen section diagnosis with the final histopathological diagnosis on permanent sections forms an integral part of quality assurance activities in the surgical pathology lab, and specific measures should be taken to reduce the number of discrepancy. Frozen sections doesn't replace the FFPA. Next, thank you very much. This is my presentation.
Thank you very much, Dr. Sjahjenny Mustokoweni, for your informative presentation. And now I would like to invite Professor Nicolaas Budhiparama from the Netherlands, but originally he comes from Indonesia. He is an orthopedic surgeon. I will read the highlights of his academic background. His education was PhD of Medicine in Universiteit Leiden, orthopedic surgery at University Leiden, and Doctor of Medicine in University of North Sumatra, Indonesia. Some fellowships from Stanford Fellowship, Cottrell Fellowship, Paris, A4 Fellowship from Germany and Switzerland, and St. Vincent's Hospital Fellowship in Melbourne, and also visiting fellowships of Harvard Medical School, Boston, Lenox Hill Hospital, New York, and Colorado Joint Replacement, Denver. And many of his academic position, including the honorary professor at Erlangga University, Surabaya, associate professor at Leiden University, the Netherlands, and also visiting professor in Medical School of Chinese People Liberation Army, Beijing. He is also lecturers in some universities in Indonesia, in Erlangga University, Gadjah Mada University, and also Pelita Harapan University. For those who would like to know completely his curriculum vitae, please contact me, and then I can send his complete curriculum vitae. Professor Nicolaas Budhiparama will talk on the challenges in knee surgery. Professor Budhiparama, the floor is yours.
Thank you, Peter. Good evening, everybody. First of all, I'd like to greet Professor Sri Maliawan, my good friend, Professor Hendy Hendartel, and Professor Andi Asadul Islam, and Dr. Frans Arifin, and Professor Lie-Kwan, and Mr. Downham, Professor Downham, and my good friend as well. He's my long-time friends, Dr. Sjahjenny and Dr. Herdiani. Today, I was asked, maybe I'm going to present it my pre-recording video. Good evening, ladies and gentlemen. First of all, I would like to thank the organizing committee for inviting me here, especially Dr. Peter Manopo. Today, he asked me to talk on the challenges in total knee replacement surgery. This is my disclosure. Currently, I'm the president of Arthroplasty Society in Asia and Middle East, and the president of Asia Pacific Knee Society, and the president of Asia Pacific Arthroplasty Society. So in concurrent, the three society in the same term. When we talk on total knee replacements, we know that the first performed that was in 1968, and now it's about nearly 1 million knee replacements performed per year in the United States. So it's among the most common elective orthopedic procedures. And if you look at the numbers, the primary knee replacements grown by 73% in the past decade, and it projected to expand by 600% by 2030. Total knee replacements, patient satisfaction is about 85 to 97% due to that pain relief and restore the mobility. And if you look at the survival in 15 years, about 95%. And the improvement in materials and technique continue to increase the effectiveness of this kind of procedure. But many patients that could be helped by knee replacements don't know about it or do not seek care. If you look at this pie, that about more than 5 years, the patient's waiting for the surgery, and it is due to the lack of knowledge, misconceptions, and the fear. Well, the common misconceptions is that too young, that the component will wear out and have to be revised, or when you are too young or too active. But the demographic now shows that 36% of the knee replacements are between age of 40 to 64. If you look at this diagram as well, that patients under 50 years that since 2000, year 2000, an increase in the amount of being operated on. And the common goal of knee replacements are reliable, safe, alleviate the pain, and improve the functions, and durable. If you look at the surgeon's goal, it's quite different than the patient's expectation. Nowadays, the paradigm shift. As a surgeon, you would like to have a pain relief and a good active daily living. It's quite stable and low infections rate and increase in survivorship. While from the patient's perspective, they would like to have a rapid recovery, improved cosmesis, high functional demand, and one procedure for the whole life. Expectations may be related to more psychologically complex subjective factors such as body image and age. If you look here, that 50% of the dissatisfied patients report no adverse symptoms from their knee. So that may be something else outside this, why the patient is still dissatisfied after the operations. It can be that the success of a surgery from a surgeon's perspective may differ from the patient's perspective. The realistic is that the pain relief, a good ADL, and walking ability. But the unrealistic is that the patient would like to have restorations of the pre-morbid functions, feel like a normal knee, and a complete return to sport, recreational, and leisure activities. This consortium, the International Health Outcome Measures, is ICHOM. It's a non-profit organization, was founded in 2012 by the Boston Consulting Group, Harvard Business School, and the Karolinska Institute. And the mission is to drive a development of standard sets of outcome measures for the medical conditions and facilitate the global disseminations and implementations of these measures in healthcare institutions. I was lucky, one of the 23 representatives from 10 countries and 5 continents, and we publish on it. And as you can see here, that we look at it, we set up a standard set for the outcome measures for the patients with a hip and or knee OA. So when we talk on knee deformity, that we have to realize that there's two things: it's bone resections and soft tissue. From the soft tissue side, that perspective, that we can have an imbalance that it causes varus or valgus or stiff knee or the flexion contracture. While the bone resections, we have to know that the femur and the tibia, the distal femur and the proximal tibia, it can be the anterior posterior, medial lateral, and rotational resections. So to have a success and longevity of the knee replacements, a proper line alignments with this 5 to 10 degree of valgus. But this we have to be careful. The question is, the Caucasian's knee the same as the Asian's knee? And of course, the design of the prosthesis, all of this is very important. And the limb should be corrected to the ideal alignment without regard to the contralateral alignments, because most of the varus deformity, it is often axis bilaterally. So we must have a good balance, and that is by the component size, level and alignments, and related to bone surgery. But sometimes the error of this knee balance, which will cause the component malalignments, as you can see here, that they not put the prosthesis properly. And this also, you look at here carefully, that the tibia shift to the medial while the femurs on the lateral. Or you will have an errors of the patella, as you can see here. It will be a disaster, or an alteration for the joint level, as you can see here from the sagittal plane, that have this posterior slope. So I would like to update you in the adult reconstructive surgery. Number one is the fixations in the replacement. You can have either cemented or uncemented, and whether a resurface the patella is needed or not. And what kind of implant choices is posterior stabilized or cruciate retaining, and well, you choose for the fixed or mobile bearing. And for the Asians and Middle East, you might like to have a patient with a hyperflex total knee replacement and a new design that is a medial pivot. Or you replace only one part, that is unique compartment knee arthroplasty. And the latest, I would like to show you about the new technology and computer assisted or patient specific implant or robotics. When we talk on alignments, it's very important, because if you look at on the left knee, that we would like to have this result and not post-operative like on the right knee. So alignments, there is some options. If you look at the coronal or frontal plane assessments, you will have a mechanical alignments, kinematic alignments, or when you operate with the robotic nowadays, you have the functional alignments. There are the two alignments is very important as well. The forgotten one is the sagittal plane assessments, and I still call this still as a mystery, is the axial or rotational plane assessment. For example, this on the left side is that the actual preoperative, and on the right is the postoperative. So you can see here the intraoperative, that you release the medial collateral and you remove the osteophyte, as you can see here, both from the femur and the tibia, and then you resect the proximal tibia, and then after that the distal femur, and you put the jig on for the femur resections with this 4-in-1, and you put also you resect also the femur, distal, anterior, posterior, and the chamfer. And the rest of the osteophyte you can remove, as you can see here, and then you prepare for the bed with the burr, and then you put an autograft here, and this is the end of the operations. So this this is very important, and I told you before, there's a two-way, is very common, the kinematic alignments and the mechanical alignments. I was asked in quite a number of conference to talks on this, and because it's very, very important. And I will start with the mechanical alignments. The purpose is to create an even load distributions of the new joint line. So the ideal would be the femoral idle angle of approximately 5 to 7 degrees of valgus. But some say that is considered only the two-dimensional alignments. This publication from Michael Hirschman shows that this is the most widely used, and because of higher reproducibility, and easiness, and the survival rate is about 90 to 97%. But although 20% of the patients who undergo knee replacement are dissatisfied in the short and mid-term, and but whatever it is, the survival remains greater than 80% at 25 years. There's another technique that gained the popularity, that is kinematic alignments. This is popularized by my good friend here, Stephen Howell. He said this considers the only three-dimensional alignments of the components. The principle is that the patient-specific and the ligament sparring, it's a bone procedures. So if you look at here the operations that you cut the distal femur equally, instead of like when you look at the mechanical alignments, you resect more on the middle side, and as well the proximal tibia, you cut it equally instead of like the mechanical alignment you can see here. So Dennis Nam, he said that recent modifications in implant designs and surgical technique have not improved. So use of kinematic alignments, more patients reporting their need to feel normal. But Young In from Korea, he said that most of the Asian patients that they have a severe pre-op metaphyseal deformity, which make it difficult to apply kinematic alignments, and the afraid is that you will end up in catastrophic failure. This is a post-operative X-ray, which for most of the surgeons is quite worrisome. If you look at the alignments of the implant, is more in a valgus. But if you compare the publications on kinematic and mechanical alignments, there's no midterm functional or radiographic difference. So kinematic alignments not recommended for routine use except for research due to potential long-term concerns of loosening. Now I move to the controversy between the Asians and the Caucasians knee. So maybe you can read this on my doctoral thesis from University of Leiden. I will start first with the anthropometric difference between the Asians and Caucasians. We have to remember that the Asian knee is not a small Caucasian's knee. So from this perspective, there's a difference in the mediolateral and the posterior measurement between the Asians and the Caucasians. And besides that, not all knee replacement systems had a good fit with an Asian and Caucasian knee phenotype. And then we published also about the reported outcome between the Indonesian Asians and American Caucasians. And from this, we found out that even though the Asian knee replacement patients had significantly worse preoperative scores, but their postoperative outcomes were comparable to the Americans. And I would like to show also the controversy of the patella. As you can see here on the right knee, it is right exactly in the middle, but there's some subluxations on the left knee. So the question now is whether you resurface the patella or not. We published this as well, that most of the American surgeons they favor for resurfacing, while the European surgeons are more selective. The Asians Most surgeons do not resurface the patella because of the patient's smaller statures, thinner patellar bones, and the additional cost of knee replacements. We also publish on alternatives to the patellar resurfacing, while the circumferential patellar denervation have a good result on it, but we do not recommend circumferential patellar cauterizations in non-resurfaced patella because there is no difference. And I published also on this patella with my Frans group, and the influence of the patella high on the replacements and the outcome on survival, because it's very important, because when you cut the lower the joint line, then you will end up with inflections limitations. And this publications is being one of the hot and the headline of the news in the American Association's Academy of Orthopedic Surgeons journal. So besides that, there's another controversy on deep vein thrombosis. We know that the Asians and the Caucasians is much different. Most of the Asian surgeons do not give any prophylaxis agents because they thought that Asian has less VTE than Caucasians. However, studies show a similar prevalence of VTE between the Asians and the Caucasian patients, so we have to be aware of. And another the nightmare for the surgeons is that you will end up with a post-operative periprosthetic joint infections. We just published this recently last year, and this comprehensive textbooks which shows that the diagnosis remain a challenge for the PGI, no gold standard axis, no uniform criteria for diagnosis axis, and no absolute test for the diagnosis. This paper from my co-authors here, J. Parfisi, shows that novel treatments and techniques are certainly needed as a current and prior strategies remain far from optimal. So I was asked by various organizations to talk globally on this PGI, and we also published quite a number of papers in the Quality One journal. And if you can see here, one, it's becoming the standard of the definition of a periprosthetic joint infections, the PGI, and the guidelines for this consortium. Last of my talk is on new technology in the replacements. Is the latest always the greatest? I've been given this talk as well for the globally and also in the France Lyon knee school. We know that orthopedic surgery is the most dynamic specialty in medicines or surgery because it has a rapid advances, curative, life-changing operations, and there's a lot of innovations. But we know that rapid advances has a double-edged sword. When it works, patients benefit. When not, then patients will be suffered, and serve to emphasize the risk of new technology. The question now is, where are we today with the joint replacements? I will show you some facts. Fact number one is that long-term data of the current knee implant design demonstrate 90 to 95% success rate at the 15 years follow-up. And it's hard to improve on a 98% success rate, and there's a chance that you might be worse. The question now, with all new technology, can computer-assisted surgery, patient-specific implant, or robotic achieve 100% of success rate? If you look at the publications, a lot shows in the past that improve accuracy and consistent alignment with the cast. So I was one of the first in Asia Pacific to receive the training of Psy back in 2004 in Australia, and it's more for the good marketing tools. And but nowadays I'm very selective in using the computer-assisted surgery and especially it's in patients with a severe varus et valgus, in femur tibial malalignments, and there is a retained implant. This is based on this two publications from my good friend from Mayo Clinic, which shows that the mechanical axis may be the wrong target in CAS because outliers have somewhat better 15 to 20 year survival. And this paper from Simon Young, recently published in 2020, shows that from 20,000 knee replacement, CAS did not confer a detectable advantage. So surgeons can achieve good long-term clinical outcome with either form of instrumentations. And this paper from my other friend John Callahan shows that in United States, that 38.3% decrease in CAS usage from 2010 to 2014. So the low percentage indicate that the majority of orthopedic surgeons avoid using CAS. As well as you can see here the guideline from the American Academy of Orthopedic Surgeons that strong evidence support for not using PSI or CAS. While Christopher Jones, he published this paper shows that the CAS usage in United States and UK is only 3 to 5%, but while in Australia about 30.8%. So given the similarities of demographic, surgeons training, and another surgical aspects, it's difficult to elucidate the reasons behind the big difference. So then we said move out of this bulky thing from the OR, and now we have a very simple handheld navigations, as you can see here. And this publication shows that the ABN or the CAS group had a significantly improved mean mechanical axis, but failed to demonstrate any advantages in a clinical outcome following knee replacement at 2 years. We published this in the core, and we shows here that this ABN not enough data published to support any functional benefit of ABN over the conventional. There's another new technology on the prosthesis, that is the patient-specific implant. So after you make a CT scan or MRI, and then you send to the company, and they're gonna make a jig like this to mold it with a 3D, and they send it back to you with this the mold. But if you look at the publication, shows that PSI does not improve the accuracy. So fact number 2 shows that patients' demand for a new technology can influence selection. Nowadays, there's a direct-to-consumer marketing, goes through internet, and the philosophy that the latest is the best. Michael Dunbar shows here, whatever it is, about 20% of there's a dissatisfied patient, and innovations in knee replacement technology has a little effect on satisfactions. Nicolaas Pagani shows on robotic. He says that the patient's preference for robotic is critical when considering patient's involvement in decision making and not the surgeon himself. The public unaware of this dubious outcome superiority of the robotic, so this giving misinformed decisions in some patients. And this robotic nowadays is a powerful marketing tool for the surgeons and the hospitals that offer robotic to be better than hospitals that do not have it. We know that the following should be considered when evaluating innovations. That much of today's innovations are fostered by the industry rather than by academia. If you look at the follow-up in 2 years only, that's underpowered and is done by a single surgeon in a single center study, and usually is popularized by a famous surgeon with an untested treatment. This paper from the Frans shows that 91% of the published papers declare their financial conflict of interest, and they reported more favorable result for the robotic. Of course, we know the positive result will get published quickly, but nobody gets promoted from publishing a negative study. Fact number 3, that new technology always comes with an increased cost. That the add of new technology is about 40 to 50% cost annually. We know that the new technology is expensive, reimbursement will decline. William Sherman, who shared this the questionnaire to the American Academic Association of Hip and Knee Surgeons, they found out that robotic increased post-operative times and not nor cost-effective. And Ferris Haddad shows here that quandary whether the recent innovations such as custom cutting blocks, navigations, robotic, and instrumented tibial insert make a difference that is worth the investment. Fact number 4, new technology comes with a technical difficulty. And I'm being asked again for the talk on these new technologies for globally. So I show you, because I also co-designer of one of the robotic. This is the way that the robot's hands cut the femur. You can see here, and we know that the current status, it is still very expensive, but uncertain returns of investments, a longer operative time, and inability for creative decisions in case of new variable. The question now is navigation helpful to inexperienced or low-volume surgeons? The answer is no, because it requires clear understanding of the goal each step by step, requires significant learning curve, and no clear impact on the outcome. Pierre Bourget shows that surgeons and hospitals should not use this approach regularly because it adds cost, have a learning curve, and with an uncertainty of novel surgical approaches. So no new approach demonstrated superiority over standard cutting guides on functional outcome. And this paper from Peter Skulko from a Hospital for Spatial Surgery shows that robotic have yet to be determined because of equivalent clinical outcome score between the robotic and the conventional. And this is one of the I wrote on for the newsletters, is that a robotic assisted knee replacement, it is a hope or a hype. As you can see here, this patient was operated in another country, and you can see here the the surgeons operated with uni with a robotic surgery, and the patient still complained after 5 months. There's still pain, and after 40 months he came to me for the second opinion, and this is the result. And the doctor said you cannot claim the doctor because the doctor following the guide of the robotic. So talking on robotic technology in orthopedic surgery, this is a good paper in current concept review in the American Journal that it's continuing innovations and future studies with a long-term outcome are needed to better evaluate the role of robotic in orthopedic. So a loaner said that whenever this translates into improved efficacy, efficiency, better outcome, and lower cost of care has yet to be demonstrated. And if you look at the long-term result at 10 years follow-up, that robotic as it does not improve long-term clinical or radiological outcome. My good friend here, the Pastor Larry Dorr, he said that robotic might not show significant difference compared to the conventional when used by a high volume or an experienced surgeon, but it may be useful for a low volume or inexperienced surgeons. But Jay Parvisi says that high-volume surgeons who can avoid it do not need it, and low-volume surgeons who need it cannot avoid it. So at the end, public perception is that prefer a robotic knee, whatever you say, by a low-volume surgeons than a conventional by a high-volume surgeon, even if results were comparable. So my summary, that the high quality of low-cost generic implant will become available. Innovations need to be supported by evidence, both basic science and clinical, and not market-driven. Progress in healthcare requires publication of positive and negative results. My conclusion is that all technologies need long-term assessments and critical appraisal. What we need is a simple robotic system that will improve patient functional outcome and alignment and the long-term satisfactions at no additional cost. and interpretations of literature is difficult for a physician trying to decide if and when to implement a new technology. My take-home message: no miracles out there. Basics of good technique, soft tissue balance, and good judgment still the key. So I would like to invite all of you to join us in the HIP&E Summit meeting. It is a meeting from the whole world globally in Bali. That will be August 23rd to 27th of 2022. Thank you for your attention.
Thank you very much, Professor Nicolaas Budhiparama, for your great presentation. We will have discussion after our presentation will be completed. So for the next, I would like to invite our next speaker, Dr. Herdiani Sulistyo Putri, anesthesiologist, and she will talk on the challenges in spinal block anesthesia. Dr. Herdiani Sulistyo Putri, the floor is yours.
Thank you, Dr. Peter. Let me share my screen first. Okay, once again, thank you, Dr. Peter. Good morning, good afternoon, and maybe good evening to all the colleagues and to all the seniors who attend the ICS Surgical Forum Chapter 25 this evening. So my name is Herdiani, and I am a staff and lecturer in Department of Anesthesiology and Reanimation in Erlangga University. So tonight I will discuss further about the challenges in spinal block anesthesia. So the regional anesthesia can be divided into neuroaxial block and peripheral nerve block. Neuroaxial block consists of spinal block anesthesia and epidural anesthesia. So the spinal block is a type of regional anesthesia in which a local anesthetic is injected directly into the CSF. It blocks motoric, sensoric, and also the autonomic response in such a degree from the entire lower body. The spinal anesthesia also used for any surgical procedure involving the lower abdomen, pelvis, and lower extremities. It is the most widely practiced anesthesia technique due to its safety margins. We can see in this picture, the spinal needle goes through the layers, the skin, and then the subcutaneous tissue, the supraspinatus and interspinosus ligament, and ligamentum flavum, the epidural space, and then reach the dura. So the cerebrospinal fluid will flow from the needle hub, confirms the correct needle placement. The advantages and the disadvantages of the spinal anesthesia. Of course, the advantages is cost effectiveness, high patient satisfaction, preserve the protective reflexes from the patient, less bleeding, and then less incidence of nausea, vomiting, and decrease the post-operative pain. The disadvantages of the spinal anesthesia are almost the same with the complication. So it must be considered before decide to give the spinal anesthesia to the patient. The indication, there are some indications, so it's beneficial for the procedure below the umbilicus. But however, recently its uses have extended to some surgeries above the umbilicus, or as well as for the post-operative analgesia. It's good for the short procedure. Some of the local anesthetic can remain until 3 hours. And it is an alternative for the patient who avoid potential respiratory consequences of intubation and ventilation. There are two parts of contraindication, the absolute contraindication and the relative. The absolute consists of patient refusal, infection at the site of injection, elevated ICP, allergy, and ongoing severe hypovolemia. The relative contraindication are local infection at the site, and then the pre-existing neurological disease, thrombocytopenia or coagulopathy, severe cardiac problems, any anatomical disorder of the spine or the previous spinal surgery, and sepsis. So the complication of spinal anesthesia, there are three: minors, moderate, and major. There can be the result from the physiologic effect on the nervous system and can also be related to placement technique. So most of the common side effects are minor and self-resolving or easily treatable, like the nausea, vomiting, mild hypotension, shivering, and others. But the more serious or major complication can result a permanent neurological damage and rarely death. This symptom can occur immediately after administration of the anesthetic or arise up to 48 hours after the surgery. Serious and permanent complications are rare. So the major are very rare, but usually related to the physiologic effect on the cardiovascular system and neurological system, or when the injection has been unintentionally at the wrong site. So the mechanism of failed spinal anesthesia, firstly, the lumbar puncture, the position, the positioning. So as we know that there are two positions in doing the spinal anesthesia, sitting and lateral. Sitting is actually easier for difficult patient than the lateral, but it can be reversed too. Like in Surabaya, most of the spinal anesthesia, we did it in lateral position, while maybe others city in Indonesia or even in other country, they did the spinal anesthesia while the patient is sitting. The role of the assistant to put the patient into the right position cannot be underestimated. And the needle insertion. So we have to make sure that the patient is in the right position, and then the correct angle, and the insertion techniques are used, even it's median or paramedian approach. And then adjunct. The adjunct is like the achieving the correct position is a particularly challenge in the patient with pain, maybe from the fracture of hip. So we can give the patient the premedication drug such as a light sedation or opioid for the analgesic. The appearance of the CSF in the needle hub is an essential for the spinal anesthesia, but it doesn't guarantee a success. So, which also requires that a fully effective dose is both chosen and actually deposited in the CSF. Knowledge of the factor influence in intrathecal drug spread and clinical experience with any particular local anesthetic preparation are important guides to choose an effective dose. To avoid the loss of injected, we should make sure that the syringe containing the injected must be inserted very firmly into the hub of the needle and check if there's no leakage. And so the needle and the syringe must be connected firmly to the fluid aspiration and should confirm the free flow of CSF. The inadequate intrathecal spread, so in the intrathecal spread of a local anesthetic solution, even when the syringe correctly placed, has truly been described as capricious or variable. And the last possible explanation for the failed spinal is that the solution injected reach the target nerves, but is inactive or ineffective local anesthetic solution or the drugs. So the failed spinal anesthesia, maybe there is no block, good block, but inadequate cephalus spread, good but unilateral block, patchy, or the inadequate duration. So having made the decision to use the spinal anesthetic, the block should be performed with meticulous attention to detail. The precise management of the failed block will depend on the inadequacy and the time at which it becomes apparent. Thus, some monitoring of the onset of the block and correct interpretation are both vital. The slower the onset of either motor or sensory block, the more likely is the block to be inadequate. If most of the expected block has not developed within 15 minutes, some additional maneuver is almost certainly going to be needed. So it's prevention is better than cure. The repeat block might be considered, but because the nerve tissue is already affected by the local anesthetic before the first attempt, so the risk of direct needle trauma is increased. It is better also to use different local anesthetic, maybe due to the maximum dose and the evaluation of the ineffective, the previously local anesthetic. To recourse to the general anesthesia, of course, there are many ways in which an inadequate block might be rescued. But we have to remember that there is a limit to how much discomfort or distress the patient can tolerate. So the general anesthesia must be considered if one or two simple measures have not rectified matters. As with any anesthetic complication, the details should be documented fully in the notes and do the follow-up initiative. Also, the patient provided with an apology and the full explanation after the operation. So, the challenges in spinal anesthesia. For a day case spinal anesthesia, of course, it's a very attractive proposition, yeah, for the day case, because it less PONV and better post-operative pain relief than the general anesthesia. But we have to significant concern of the risk of post-dural puncture headache, PDPH, the effect of the bladder function, and the delay of recovery motor function. We can use the smaller and atraumatic spinal needles to reduce the incidence of PDPH. But we have to make sure that the complete recovery of motor block and the independent ambulation are required before the discharge of the patient. Both the drug and dose used for the day case spinal anesthesia must be chosen carefully to allow the successful ambulation but maintain the block efficacy. There are some cases that need maybe unilateral spinal anesthesia, mostly for the orthopedic surgery with one side of surgery, because it can reduce the cardiovascular side effect and earlier patient mobilization. The gravity had no effect on the spread of isobaric solution, while the hyperbaric solution of local anesthetic did indeed spread under the effect of gravity. It was found that the posture could not be used to control spread effectively, but if we put the patient into the remaining position or lateral for 1 hour after the injection of hyperbaric solution, it can maintain the unilateral anesthesia. But however, there remains no conclusive evidence and that the use of small doses of hyperbaric solution can be used to provide spinal anesthesia that exclusively unilateral. Because this is still in pandemic in COVID, so the neuroaxial blocks may be considered preferred methods of anesthesia in the presence of respiratory disease risk. But we have to aware for the hypercoagulation status. It's common in patient with COVID-19, but the unknown of this disease and the medication of the patient must require special attention to the preoperative coagulation status. Many of COVID-19 patients have underlying cardiovascular disease, and a lot of them develop acute cardiac injury. So therefore, special attention to the patient's heart condition before spinal anesthesia is particularly important, so that if there's a cardiac disorder, appropriate measure can be taken to maintain the hemodynamic stability and prevent the unwanted hypotension. Spreading of the SARS-CoV-2, the central nervous system or the CNS, can cast doubt on the safety of the spinal anesthesia. The mechanism of this neuroinvention is still not fully understood, but maybe neurological symptoms such as headache, consciousness disorder, paresthesia, and other pathological signs can interfere with the block evaluation following the spinal anesthesia. For the difficult airway, particular attention should be paid more to airway exam before performing any regional anesthesia. If the COVID-19 patient is considered a case of difficult airway, it may be futuristic to have general anesthesia at the set. So if the regional anesthesia suddenly fails, the airway management will not be in an emergency situation. That will increase the risk of the virus transmission to the operating room for the medical personnel. The COVID-19 patients are more anxious than other surgical patients entering the operating room. So the administration of the anxiolytic such as midazolam as a pre-medication prior to the anesthesia in these patients is not just a suggestion, but a strong recommendation. Lastly, the most important thing in anesthesia management is to establish a balance between the benefit and risk. Undoubtedly, keeping away from the patient airway is more important for the protection of the healthcare providers, but the distance from the airway cannot be used as a basis for the anesthesia management. So I would like to explain a little bit about spinal anesthesia in ERAS. So ERAS is a multimodal, multidisciplinary fast-track surgery, also known as enhanced recovery after surgery or enhanced recovery pathways. So ERAS refers to evidence-based protocols that standardize care to minimize surgical stress response and post-operative pain, reduce the complication, improve outcomes, decrease the hospital length of stay, and expedite recovery following elective procedure. The key elements of ERAS protocol include pre-operative counseling, optimization of the nutrition, standardized analgesic and anesthetic regimens, and early mobilization. So actually, firstly, the ERAS protocol is introduced to the colorectal surgery, but it has been used in almost all cases, such as obstetric and gynecology, urology, orthopedics, and extra. We can see the guidelines for each procedure in the erassociety.org. So the general of ERAS principle consists of optimization in pre-operative, and then stress reduction during or perioperative, and also the protocolized normalization in post-operative. So during the pre-operative, even from the pre-hospital, from the patient, since the first they come to the surgeon, we do the counseling and education, and also the patient optimization. Before the day of surgery, we give the patient carbohydrate loading, and then no prolonged fasting, and we start the PONV prevention and multinodal opioid sparing analgesic earlier. In perioperative, put the patient in normothermia. We use the short-acting anesthetic, and then the surgeon will give the small incision in the surgery site, and also minimize the drains and the stand. In post-operative, we have to stratification the risk. Will the patient go to the ICU or high care unit or into the ward? We give early oral nutrition, continue the multinodal analgesia, early mobilization, early removal lines and drains, and we continue the PONV prevention. So the evidence for the spinal anesthesia in ERAS. So within the context of ERAS protocol and open surgery, spinal anesthesia was the mode of choice compared with epidurals or PCA. PCA is patient control analgesia. So the patient can adjust the dose of the analgesic drugs by themselves. Another clinical trial compared spinal anesthesia and PCA. So post-operative opioid consumption in the spinal group was significantly less over the first 3 post-operative days, but had no other advantages over the systemic opioids. And the original ERAS guideline noted that a regional anesthetic block, in addition to general anesthesia, can minimize the post-operative intravenous opioids. The recommendation was that the mid-thoracic epidural blocks using the local anesthetic and low-dose opioid should be considered for open surgery. And in laparoscopic surgery, spinal analgesia or morphine PCA is an alternative to epidural anesthesia. The modified recommendation suggests avoiding opioid with multimodal analgesia, including spinal or epidural analgesia or TAP block when it is indicated. So the summary of my presentation tonight, the spinal anesthesia is the most widely practiced anesthesia technique due to its safety margin. Consider the benefit and the risk, also the indication and contraindication. Avoid the complication and failed block by using the correct techniques. Put the patient into the right position. Make sure to use the right dose of the local anesthetic, and do not hesitate to communicate with the patient and also the surgical team. Spinal anesthesia is usually a simple and effective technique, but failure can occur at any time in the hands of any clinician, no matter how experienced the anesthesiologist is. The drug, dose, techniques, and equipments used for day case or unilateral spinal anesthesia must be chosen carefully to maintain the block successfully. And the spinal anesthesia can still be the one of the recommended methods to reduce the risk of infecting the operating room staff. In other words, the relative and absolute contraindication for spinal anesthesia are precisely the same for COVID-19 and non-COVID-19 patient. In eras regional anesthesia alone or combined with general anesthesia are preferred to reduce the dose of systemic opioid and for getting multimodal and fast-track surgery. This is also the challenge, actually, if you give the spinal anesthesia, if the patient suddenly go up to the lamp in the surgical room. So thank you. I will give back the time to Dr. Peter.
Thank you very much, Dr. Herdiani, for your very informative presentation. And now we come to the discussion session. But before having discussion, I would like to invite Professor Andi Asadul Islam to address the summary notes. Professor Andi, the floor is yours.
Yeah, thank you very much, Dr. Peter. And I most appreciate for the three speakers with some speaks. So, especially for me, myself, is give me some information about, especially from Prof. Nicolaas, is about knee replacement, and also Dr. Sjahjenny about pathology for the intraoperative pathology, and then also for Dr. Herdiani. My son is right now is training in I mean is resident in Orthopedic, and I would like to pass your slide for them. Thank you very much for the very good speaks for three speakers tonight, this evening. And also for Dr. Peter, especially Dr. Peter Johannes Manopo is my friend. It's most appreciate to always give such information about the ICS. Thank you very much for all of you.
Thank you very much, Professor Andi Asadul Islam, for your summary notes. And now I would like to open the discussion. But before opening the discussion for the floor, the first part of the discussion will be the inter-speakers discussion. So each speakers may ask question each other about their topics that related with the interest of each speaker. So I would like to invite Professor Dr. Sjahjenny Mustokoweni for the first opportunity to ask question to the other speakers. Dr. Sjahjenny, the time is yours.
Yes, thank you, Dr. Manopo. Yeah, my field is in oncology. I think it's close to Dr. Herdiani with the frozen sections. Sometimes we get the prolonged process, the frozen section, because the case is difficult, or perhaps it's very rare, and maybe there is no discussion, the previous discussion between the pathologist and the clinician, the surgeon. So what will you do with the situation that the patient under anesthesia, that sometimes makes us also think about that. We also consider about the prolonged anesthesia for the patient. What is your opinion, Dr. Herdiani?
Dr. Herdiani,
Yes.
would you please react to this question?
Yes. Thank you, Dr. Sjahjenny. In those kind of cases, actually, if in my experience, first I will ask the surgeon how long will it takes usually for the frozen section, and if I can meet the pathology, I will also maybe 1 hour or 2. Okay, then before I will explain to the patient, because if we do the regional anesthesia, especially in spinal anesthesia, it for the only short procedure, the maximum is maybe around 3 hours. But if we combine with epidural, or maybe we did the peripheral nerve block, we can wait for more hours for the anesthetic drug remained. So usually the anesthesiologist will ask first for how long, and then we will decide whether we can use the spinal, or we use combine, or we use the general anesthesia. Maybe that can answer your question.
Thank you.
Thank you very much, Dr. Herdiani.
Yeah, for the next opportunity, I would like to invite Professor Nicolaas Budhiparama to ask questions to the other speakers. Professor Budhiparama, the time is yours.
Thank you, Peter. I would like to ask my long-time friend, Sjahjenny, for the bone tumor, do you still do any possibility for doing a fine needle biopsy?
Yes, we do. To screen the patient, because with the FNA, we can we can split whether this is a benign or malignant lesion. So if basically we have to do the triple assessment. If the triple assessment is met, so the patient goes to the definitive treatment. But if not, the patient should have some like a core needle biopsy or frozen section. But frozen section is not recommended due to the specimen content with the bone. That's Prof.
Thank you. May I ask also Dr. Herdiani?
Sure.
You mentioned on your talks about the fast track. I'm very interested on it because we are preparing a textbook for that with my American and European and in Asians. But can you share with us your experience on it for mostly in the Indonesian patients or Asian patients? Because like in United States, even that we operate sometimes that for the knee replacements that they do a day surgery, while probably in Asian country they don't want it. They said, "Hi, I have my health. I have someone's taking care of me, a lot of family with me. Why do I have to have a day surgery?" Can you give a comment on it, please? Thank you.
Yes, Prof. Thank you for the question. Actually, in my experience, there are still some cases that we do. So mostly is an obstetrics for the cesarean section. Yeah, we did some ERACs. We still ERACs with cesarean because maybe it's different cases with orthopedic, Prof. So the patient is more satisfaction because they can go home earlier to be at home with the baby. But in orthopedics, yeah, it's still maybe for simple surgery, like maybe the lower extremity, but not in femur, maybe, or knee replacement. It still have maybe 2 or 3 days, and then, I mean not a day case surgery in in my experience. But we did some, most cases for the ERAS in cesarean section, and most patients are satisfaction, have a great satisfaction.
Thank you. Thank you so much, Dr. Herdiani.
Yes.
Thank you, Dr. Herdiani. And now I would like to give the opportunity to Dr. Herdiani. Do you have any question to the other speakers? Time
Yes.
is yours.
Thank you, Dr. Peter. Maybe for Prof. Nicolaas, in my experience with the orthopedics, usually for the knee replacement, because I'm also in regional and pain management division, so they put local anesthetic, and sometimes they mix with the non-steroid anti-inflammation drugs to the patient, to the site of surgery before they closing it. They said it will give a good post-operative management in knee replacement after the operation. What do you think about that, Professor?
It's a very good question, Sjahjenny. I'm going to say like this. If I trust you as my anesthesiologist, you're very good. I don't need to give any local anesthetic. It's like what we call a cocktail, you know, because I trust you. No, just kidding. No, actually, it's like this. It started with my good friend from Hospital for Special Surgery, that is Professor Renawat, who found this cocktail. Because according to him, is that, you know, when you give an only a blocking and a femoral block or whatever it is, and it will be not long lasting. Well, he did some study on it, and he said that it works. But the problem is, the question is, in some patients, it may develop an infections. Yeah, that is what is worrisome. And if you ask me personally, I still give it the cocktail. We call it cocktail, but depends on if the patient's diabetic patients, and then we don't mix it with the steroids. That is, yeah.
Thank you, Prof.
Thank you.
Thank you, Professor Nicolaas Budhiparama. And I would like now to open the discussion to the floor. Any question from the floor to the speakers? You can ask directly and then introduce yourself. And who would you like to address the question? Please. While waiting, I have a question to Professor Nicolaas Budhiparama. Is it possible to avoid the surgery directly by advising the patient for the muscle exercise, the quadriceps setting or the hamstring or something like that, so that we can avoid the surgery directly? First, to try by the muscle exercise or how to walk or other weight-bearing activities properly.
Yes, thank you, Dr. Peter. I think that is typically, you know, like you have, I think you have a little bit Dutch blood, because in Europe, we are more conservative, you know. So, I mean, like we not go jump like for that operation. So if it is possible that we try to modify, you know, you modify your lifestyle and you strengthen your quadriceps and hamstrings muscles. But most of the, you know, there's a different perspective. Some doctors, especially in Southeast Asia, they claim, hey, Dr. Peter, you are still young. You are, I don't know how old, 60 or 65 or whatever. Let's do the knee replacement so you can still enjoy your life, the rest of your life. But they forgot one thing, that these knee replacements or hip replacements, that there's no without any complications. And you know, the lifetimes that they claim first is 15 years, 25 years. But again, for me, if it is possible that we do a conservative treatment first, I agree with you. So, and my indications is, I said to the patient always is that does it disturb your lifestyle or not? Because you can have a grade 4 that which you this indication for total knee replacements, but then you say, hey, I'm still playing golf. Why do I need a surgery? Well, you have another patient's grade 3, but then you say she cannot walk and even sleep at night. When she would like to go to the restroom, she's not able to walk. And that is one of the indications that you might need surgery.
Mm-hmm.
Yes.
Yeah, thank you very much for your explanation, Professor Nicolaas. Is there any question from the floor?
Dr. Peter, there is one participant that raised hand. I think it's Dr. Nisrina. Maybe
Dr. Nisrina,
like to...
yeah. Yeah, please, Dr. Nisrina.
Okay. I hope everybody can hear my voice. Good evening, everybody. Thank you for the lecture. I do have a couple of questions specifically for Professor Nicolaas. My name is Widari. I'm currently working as an orthopedics clinical assistant in RSUGM Jogja. So Professor Nicolaas, if I may kindly ask you, the first one is, in your opinion, how much potentials does 3D printed knee arthroplasty have in the future, since most Indonesian knees are mismatched with the currently available knee designs? Even in your paper, you mentioned, you compared from 9 different designs. And for the second question is, in one of your papers, Indonesian patients were reported to have worse pre-op conditions relative to the Dutch Caucasians. And for that reason, I deduced that TKA is more commonly used in Indonesia. Thus, how often is UKA used in the Indonesian population in reality? And how has been your experience with UKAs in this country? Other than worse pre-op clinical conditions, limited insurance coverage, and the surgeon's own experiences, what might be the other challenges in implementing UKA in Indonesia? Because I'm particularly interested in whether UKA is promising early intervention in Indonesia, just like in other developed countries. Thank you very much in advance. I look forward to your comments and feedbacks. Thank you.
Thank you. So how do I call you? Nisrina or Widari?
You can call me Widari, Prof.
Yeah, I like your questions so much. You know, it shows that you read a lot. But which semester are you in now?
I'm a freshly graduate doctor, so I just finished my internship last November.
Amazing. Yeah, yes, very good. So your question is very sophisticated questions, like the 3D printing, and which is nowadays is becoming on, you know, and especially I agree with you that they developed well is in United States or in Australia with the 3D printing. But you know, in the United States or in Australia, the cases that they being operated on is not that advanced compared to the one in India or in China or in Indonesia. And that is one of the reasons I show you on my paper with the Americans, with the Hospital for Special Surgery, that we compare the patient who come to the doctor in Indonesia, that or in another rest of the part of Asia Pacific, that they postpone to go to the doctor. One thing that they said, they're afraid that when they go to the doctor, the doctor may suggest for an operation. Second, then they wait until that the defect is becoming so bad. And so in that case, actually, that is the one, but you might need the 3D printing. But don't forget, 3D is still quite expensive. So, but that is one of a, you know, for the revisions, I did in Leiden with a 3D, because the revisions, you never knows how to fix it. So you cannot just look at your CT scan or MRI and then you create what kind of surgery that you might need it. And that is the case, you might need a 3D print. Your second questions on uni, it's a very good questions. what's your name again? There is that media, because you know, I introduced this in Indonesia back to 2005, that for the uni. But the problem is in the developing country, or in Indonesia, or in India, when the patients come to you, there is a good indication for a uni, because it's just a minimal defects on the medial or lateral condyle. The patient, when you offered for surgeries, they said, no, I'm still walking, I still can kneeling. Why do I need to be operated on? But that is the good indication for operations. But now, if you look at, I published also with my team in Europe, you can read it on uni. You know that uni, the indication, it has to be very strict, because in my perception, if the patient is younger than 60, I offered a uni, but not if it is above 65 or 70, because you operate on the uni on one side. Within 2 years, they will develop another arthrosis in the other part, because you know that a knee has three compartments: medial, lateral, and patellofemoral. So you don't want that the patient come back to you and said, you are not a good doctor, because you know I feel more pain on the other side now, and you offered for the revisions. That is my answer. Thank you very much for the question.
Thank you, Dr. Professor Budhiparama and Dr. Widari. Any other question from the floor? While waiting, I have one question for Dr. Herdiani. Dr. Herdiani, based on your experience in spinal anesthesia, what was the most difficult problem, and how did you fix this problem? Maybe bleeding, or maybe technical error that caused the complication to the patient. Thank you.
Thank you, Dr. Peter. Actually, the most difficult problem in spinal anesthesia if we have a total spinal block. So that's the highest spinal block in spinal anesthesia, because the patient can apnea and then can directly to the cardiac arrest. So in case of all regional anesthesia, whether it is neuroaxial or peripheral nerve block, the anesthesiologist should prepare for the general anesthesia or for the emergency intubation if there's some complication, like the worst is the spinal block. Most of the cases in high spinal block or total, I had two experience in high block, not total spinal. The patient complained deep snoo, and she was breathing hard, and severe hypertension, and then bradycardia. So we have sadly to switch to the general anesthesia. So I intubated the patient and then explained to the family and the patient after the operation.
Okay, thank you, Dr. Herdiani. Any other question from the floor?
May I ask a question, Dr. Peter?
Oh, please, Dr. Frans.
Yeah. I have one question for Dr. Sjahjenny and for one question for Prof. Nicolaas. The first is to Dr. Sjahjenny. We have in our hospital, we have worked together with the pathologist there in doing the frozen section. But when I discussed with the pathologist that the frozen sections can only be used mainly to determine whether it's malignant or it's not malignant. In your presentation, you mentioned that there are a lot of things that information can be gained. There are a lot of information can be gained from the frozen section. One of the most interesting thing is that we can know which organs that we are or from which organ the cancer arise. Is this a standard procedures that the reporting of the frozen section, or maybe the standard is only to determine whether it's malignant or it's a benign lesion? My focus is on the pancreatic tumors, which is quite difficult. So I rely a lot from the determination of the pathologist to decide whether I would have to perform the Whipple surgery or not, only bypasses, because it's we know a lot of complications that is related to the major surgery. So this decision, the pathological information of the lesion is very important for me. Would you kindly explain whether this information, all of those informations are generally can be acquired from frozen section? Should I continue, Dr. Peter, to Prof. Nicolaas, or
possibly one by one? It's better.
One by one. Okay,
Yes.
thank you.
Please,
Thank you, Dr. Sjahjenny. Please answer. Thank you very much.
Dr. Sjahjenny, would you please react to this question?
Thank you, Dr. Frans. You know that the problems, especially in pancreatic tumor, as I said, that we cannot make sure whether it is only pancreatitis or malignant, because the structure of the tissue. So usually then we said that, yeah, we have to wait for the paraffin section. Because you know that pancreas itself, it is also difficult in surgical technique also. Yeah. So it's different if we find the fibroadenoma comparing with pancreatitis. It is stressful for us to make a decision. So it is the first thing is the discussion between the pathologist and the clinician. With the radiological information, usually we make a tumor board or something like that. It's everything, every decision came from the team, not from the pathologist only. Yeah, so. And about the report, usually we made from the macroscopic, and then what microscopic finding, and then the conclusion. Sometimes, usually we can say that it's benign, true benign, or true malignant, or if in the gray area for pre-malignant, we cannot say directly. So we have to wait for the paraffin.
See, thank you very much. So I know that it is a challenge also for the pathologists because
yes, sure.
it's also a challenge for the surgeons,
yes.
And it's a quite difficult decision for us also because the consequences of the surgery. Thank you very much, Dr. Sjahjenny. The second questions?
Yes, you may proceed to Professor Nicolaas.
Yeah. Yes, thank you much, Professor Nicolaas. A very interesting and comprehensive presentation. I'm not an orthopedic surgeon, but I can enjoy the presentation very much. One of the interesting thing that I noticed is that the expectation of the surgeons and the expectation of the patients may be very different. Now, what do you think we should do? I mean, we as a surgeon should do something and decide something, right? Whether we operate or whether we do a conservative approach, the strengthening of the muscles or other things. But what if the patient wanted something and we know that it might not be the best, in our opinion, the best way for the patient, but if you remember, some people say that the patients knows the best, not the doctors now. So should we follow their request? Should we do the surgery because of the cosmetic reason, for example, while the functional is still fine? how do you resolve this dilemma? I don't know whether it's a dilemma or not, but in my practice is also sometimes the patient requested something that we know that it's not quite necessary now. We can wait. So please advise. Thank you very much, Professor Nicolaas.
Thank you very much, Frans. It is a very, very good questions. Number one is that sometimes the question is the indications. Is that indications based on market driven or on page from patients or you as a surgeon? You know, because I teach globally in United States, in Europe, and in Middle East, and in Indonesia. I'm working in Surabaya now, in Erlangga. So it's again. So you must have the in some it is based on where you are educated. In some, if you are like it's more finance that all the patients. Some patients they said, yeah, Professor, I would like to be operated. And you say, hey, that's not the indication yet. So it's from your heart. Are you going to follow the patients or not? That is your second question. But your first question, this is very interesting questions, because whatever you do in knee replacements, that we have a lot of headaches. That 20% of the patients still claim that you don't do a good surgery, doctor, because I'm still feeling pain. And you look at this, the X-ray, you look at the function, you say, hey, this is all, looking good. And I am just 2 weeks ago, I graduated from my other PhD. Yeah, I like to do PhD. My other PhD is on genetic. Now I'm thinking of, is that no other thing on genetic, for example, and I found out that in Asian populations that we have 3 SNPs, that it will cause if you found it in the blood, you can find in the blood, and then you look at epigenetic. Is that one of the reasons that that this kind of patients might have later on or cause a problem because of the inflammations, and it is still there, though that you operate you remove all the defects of the bones defect, but not the soft tissue, right? So that's what I'm thinking of. I think I would like to have a bigger sample with my American and European and Asians to think of, is that not another reasons for the unsatisfied patients. But of course, number one is the expectation is different. So in my hand, I always say to the patients, what do you expect of the operation, after the operations? That is very important, and not based on you look at the X-ray, it's a grade 4, then you say, yeah, you might need an operation. No, you ask the patient, but what do you expect after the operation? Yes. Thank you, Dr. Frans.
Thank you very much, Professor Nicolaas. Back to you, Dr. Peter. Thank you very much for the opportunity.
Thank you.
Just a reminder, I think there is a question in the chat box.
Maybe Dr. Hefson, Dr. Hefson Agung, you may ask directly the question to Professor Nicolaas. Dr. Hefson. Okay, the question of Dr. Hefson is to Dr. Nicolaas. What are the signs that emphasize on opting for robotic surgery rather than the conventional or the regular surgery? What is the most important consideration for robotic surgery? That is the point of Dr. Hefson. Would you please explain, Professor Nicolaas?
Yes, thank you, Peter. It's against that, when all innovations, there is no innovations without evaluations. So if you said, like the time the computer-assisted surgery, I was one of the first. I told you, right? I come and then everybody, I'm giving lectures all over the world about the computer navigations. But then you wait for another 10 years, then you see, is there any benefit of this computer? And now robotic, it is more hype or hope. So you know, for the patient, oh, this doctor operate with a robot. Of course, it's better than the other doctor who doesn't operate with a robot. My question now is always like this: if you know from my house to go to University Erlangga every day I go there, do I need a navigations? Of course not. You know, in some difficult cases you might need. So again, I mean, the robotic is just recently, I mean, though that I'm one of the designer, but I have to be very frank to you that it is the follow-up is only about 2 to 3 years. From the Korean papers, they claim that 10 years already, and they found there's no benefit or compared to the conventional. Yep.
Thank you, Professor Nicolaas, for your explanation. I think we are approaching to the end of this webinar.
One question, Dr. Peter.
Oh, okay. Yeah, Professor Hendy, please.
Thank you. I want one question to my best friend, Professor Nicolaas. Nice to meet you. Good to see you. I have question to Professor Nicolaas. Nowadays, we often see the use of stem cell in orthopedic surgery. My question is, can stem cell be used in knee replacement surgery, for example, to improve the healing process, etc.? Thank you, Professor Nico.
Yeah, this is a very good question, Professor Hendy. Professor Hendy is my boss now, and this is a very, very good question. We publish on stem cell on ACL, anterior cruciate ligament, with the radiologists from UNAIR, Dr. Rosie. And that is when we do an ACL reconstructions, if we inject the stem cell, that the healing, the process of the bones is faster by several months. But how about injection of a stem cell is still a controversy, because you know the stem cell is good for the skin, for the heart operations or cardiologists, but not yet proven for the bones. So that's why if you look at the stem cell in United States, it's not that popular. In Europe, it's only in Germany and some part of Switzerland is very popular, but not the rest, because the fact is that it is more like a marketing, because so in the knee replacements, whether you inject the stem cell, that they will improve the pain or what post-operative is not yet proven, Professor Hendy.
Thank you.
To Professor Nicolaas, regarding to the question of Professor Hendy, is it the same answer for the platelet-rich plasma to inject into the osteoarthritis of the knee?
That is another good question, Dr. Peter. That the PRP, it is also not proven. And you know, when I was in the Codiatic, I was a Secretary General of Codiatic, and that time, that was back in 2015, that we give a publish on that we said that it is not proven, and sometimes there's some complications on it. But it works for a tendon problem, tendonitis, or for the athlete, it works, but not for the OA. But you know, as a doctor, sometimes you would like to have a patient goes to other doctor. They say, yeah, the doctor just give medicine, so I can give you an injection from the blood, and then it will heal. That is more for marketing.
Okay. Yeah. Thank you, Professor Nicolaas. So I think, is there any other question from the floor? Last question, maybe. Okay, this is a closing question to Dr. Sjahjenny. Dr. Sjahjenny, if the result of the frozen sections will be different with the examination of definitive paraffin block, how do you think? Is it maybe potentially will be an ethical problems or just technical problems?
Thank you, Dr. Manopo. Actually, this is the crucial part of us in pathology. The discrepancy result from the frozen section and histology. we have to look from several sides. First, there is communication. So communication is very, very important. I means that we should talk before the operation. So this is the importance of the tumor board multidisciplinary team, that every decision came from the team, not from the individual. So it is also go to the ethical or maybe the issue from the patient or their family, or maybe from the hospital. It's complicated. So that's why if we get the result on the gray area, so we have to wait from the paraffin. If it is true white or true black, is okay. But the problem came from the gray area.
So
yes.
I have a further question regarding to your explanation. Is it necessary to make a panel review? So there is more than one pathologist makes as a team for reviewing the problem or the difficulties in the reading of the pathologic examination to avoid the multi-interpretation.
That's right. It's
Do you
true.
agree? Do you agree with that?
Yeah. Yes, yeah, we do. We do. Usually, if there is a problem like that, so all of some are several pathologists, then we'll discuss and make a review, and then if it is necessary, then we go to the further examination. Yeah, maybe we need like immunohistochemistry, something like that.
Okay, thank you very much for your explanation. Dear participants and all speakers, I think we already came to the end of this session. On behalf of the International College of Surgeons Indonesian section, I would like to express my gratitude to all speakers, Dr. Sjahjenny Mustokoweni, Professor Nicolaas Budhiparama, and Dr. Herdiani Sulistyo Putri for contributing in this webinar, and also for the ICS-World Office Bearer, Mr. Max Downham, also to section officer, Professor Hendy Hendarto, Professor Sri Maliawan, Professor Andi Asadul Islam, and Dr. Franciscus Arifin. But for the closing speech, I would like to invite Mr. Max Downham to address the closing speech. Mr. Max Downham, the time is yours.
Well, thank you, Dr. Manopo. I will be very brief. First of all, you always flatter me. For those that don't know, I'm not a physician, not a surgeon. I'm a layperson, so I listened to all of the comments and presentations. They were all very well done. Slides were great, and having experience not only here in the college but prior in business and in the military, when the word team is mentioned, it indicates, amongst other things, communications to me and to all of you, I'm sure. I listened for that, and Dr. Herdiani in her last comment talked about the team and communications, how important it is. I can only imagine that it's communications amongst the anesthesiologist, the surgeon, and the pathologist. And I heard, I think Dr. Budhiparama mentioned trust and one of his answers, and so forth. So communications are extremely important. It seems to me from my lay perspective, and I sense that in all of the presentations. So Dr. Manopo, again, thank you so much. I turn it back to you.
Thank you, Mr. Max Downham, for your closing speech. Again, I would like to express my gratitude for all participants, all the speakers, and also for our IT team, Mr. Bimo and Ms. Devi. So we will meet again next month with another topic with other speakers. And I think good evening, good night, good morning, and good afternoon. We will see again. Hopefully you will be healthy and fine. Goodbye.
Goodbye.
Thank you very much.
Thank you.
Thank you very much, everybody.
Yeah, thank you. Thank you. Thank you, Professor Nicolaas, Dr. Sjahjenny, and Dr. Herdiani, Dr. Frans.
Thank you, Dr. Peter.
Thank
Dr.
you.
Hendi, Prof. Hendi, Prof. Andi Asadul,